and who's going to be talking about loss of vision in Wolfram syndrome.
Right. Good afternoon, everyone. Can everyone hear and see the slides? Good. All right. I'm just going to minimize this here. Right. Well, unfortunately, again, this year we can't meet in person because of the ongoing, hopefully, tail end of the COVID pandemic. But hats off to Tracy and the other organizers for keeping the annual meeting going, given the current circumstances. So hopefully, perhaps next year we can all meet in person, and reconnect really after more than a couple of years. I'm an ophthalmologist by training. I work both in Cambridge and in London. I subspecialize in neuro-ophthalmology and also genetics, which has been a major area of research for myself over the past 20 years. And as we started to understand more about the genetic causes of these inherited optic nerve diseases, I became more and more involved with looking after patients with Wolfram syndrome, and also starting to do some research in this condition, both from a clinical perspective and also more about the basic science. And it's been a real pleasure being involved with other groups which have been working on this for much longer than I have. People like Tim Barrett, Fumi in St. Louis, the whole French group based in Paris. And, essentially we need such a diverse group of investigators because it's quite challenging doing research in rare diseases. And increasingly we're being faced with challenges with securing funding as well. What I want to do in this presentation is give you start from the basics to give you an indication about how the eye gets affected in Wolfram syndrome, how you end up having visual loss, and some of the approaches that we might envisage in terms of preventing ongoing visual loss, which is a major problem for patients affected with this disorder. So I'm going to give you some explanations about what we mean by optic atrophy. I'm going to talk about the visual prognosis and the reason why we need to find treatment for this condition, and also about the approaches that we can use, either drugs or gene therapy or a combination of both, where we are now and where we can go in the future. There will be people who will be joining this meeting for the first time, and I think just to give you an indication about how the eye works, I'm going to give you a few slides just now. So this is essentially what you see when you look at yourself in the mirror. You have the white of the eye, you have the colored part of the eye, and then in the center you have the pupil, which allows light to get into the back of the retina. And if you look at the eye in cross-section, what you can see behind the colored part of the eye, which is the iris, you find a crystalline lens. And the crystalline lens is there to focus the image on the back of the eye. And the reason why you need the lens is it allows you to have a much more focused view of the picture that you're looking at. And at the back of the eye, you have the retina. So if you take the analogy of the eye being a camera, the retina is a film at the back which is sensitive to light and which allows the light to be converted into an electrical signal. And this electrical signal is then transmitted down the optic nerve towards the brain. If you look at the retina, it consists of a number of cells structured into these various retinal layers. I'm not going to go into them in any great detail, but one of these layers is known as the retinal ganglion cell layer. And it is very important because it is a final layer, and it is the retinal ganglion cells which will transmit this electrical signal from the eye to the brain. And if you look again at this cross-section of the eye, the projections of these retinal ganglion cells converge at the back of the eye, and it forms a bundle, right? And this bundle is known as the optic nerve. When you're born, you probably have roughly around 1.2 million retinal ganglion cells. And in various diseases, whether genetic or acquired diseases, you lose these retinal ganglion cells. And because of the loss of these retinal ganglion cells, you end up with optic nerve damage and you end up with visual loss. So the connection from the eye to the brain is again quite complex, but of course you need the optic nerve as a first stage of this pathway. And if you have any problem along the pathway from the optic nerve to the brain, you can end up with visual loss. Different forms of visual loss, but nevertheless, this can have a major impact on someone's quality of life. So the optic nerve really is a fast broadband cable that connects the eye with the brain and transmits the visual information. If you look at the back of the eye, which is something that we do all the time in the eye clinic, this is what you see here. A nice golden yellow optic nerve, and out of the optic nerve, you can find these blood vessels emerging. And the reason why you have these blood vessels is because the retina is very high in terms of its demand of oxygen and sugar, and therefore you need to supply enough blood to be able to allow the retina to work perfectly well. So this is a healthy looking optic disc. If you look at the retina as well, there is one specific part of the retina which is known as the macula. And the reason why we're very concerned about the macula is because this is what gives you your central vision, your 6/6 level vision. And if you end up having a problem with your macula, you end up with losing your central vision. So this is again just a cartoon, but it gives you an indication of how much vision you lose in the central part if you end up having a disease which affects the macula and this specific bundle, which is known as the papillomacular bundle. So what happens if you have optic nerve damage? It all depends on how quickly it happens and which part of the optic nerve is damaged. But essentially, in Wolfram syndrome, you end up having pretty global damage to the optic nerve. So the whole of the optic nerve becomes damaged, and you end up with the optic nerve becoming pale. So this is quite an obvious change that you can see here. So when the nerve becomes pale, this simply means that there has been damage. And unfortunately, in Wolfram syndrome, the damage is progressive. And as you can see in this picture here, the whole of the optic nerve has become pale. And the medical term that we use for this is optic atrophy. The reason why this is a challenging condition is you end up losing vision from a very early age. And the rate of visual loss tends to be quite rapid, so that by the time someone reaches their late teenage years, a large proportion of these patients will be registered legally blind, at least based on the UK standard. And you have heard from other people last week, from Fumi, you have heard an update from Tim earlier on, and that's the whole aim of treatment for Wolfram syndrome, not only try and improve the other components, the endocrinological component, the neurological component, but also to try and minimize the impact of progressive visual loss on patients and their families. This is one of the guidelines that has become, a kind of, major, reference point for us, because we need to have ways of diagnosing Wolfram syndrome, or perhaps what we should be labeling as being Wolfram spectrum syndrome disorders. But nevertheless, the two key features are the onset of diabetes before the age of 16, and also optic atrophy, i.e. optic nerve damage, before the age of 16. So these are the major diagnostic criteria for Wolfram syndrome. When you look at various publications, there is a bit of variation about what's the proportion of people with Wolfram syndrome who have optic nerve involvement. In my personal experience, if you look hard enough, you will find evidence of optic nerve damage. Sometimes it can be quite subtle and you need more sophisticated testing, but the optic nerve, for sure, it's one of the major organs which is selectively vulnerable to the underlying pathogenic problem linked with WFS1 mutations. So which brings us directly to the genetics of Wolfram syndrome. I'm not going to go into too much detail about this, but I think it's quite important to get a flavor of how genetics works and how it can impact on someone's daily functioning. So when we talk about recessive disease, we need to keep in mind that we all inherit half of our DNA from our father and half from our mother, right? So in this cartoon here, you can find that both mom and both dad carry one good copy and they carry one bad copy, right? So for both of them, they do not have any genetic disease because the good copy is sufficient to provide all the proteins needed for normal function. But then if they have children, you can end up with three scenarios. In the best case scenario, the child only gets the good copy from mom and dad, and they are unaffected. However, you can end up in a situation where they inherit the one good copy and one bad copy. And again, they will not be affected by this genetic condition. But in about 25% of cases, 1 in 4 being the odds, unfortunately, you inherit both the bad copy from dad and the bad copy from mom, and you end up with the genetic disease. So this is what we mean by recessive disease, where both copies of the gene need to be affected to result in a problem. When we talk about dominant disease, it is different here, right? So in this cartoon here, one of the parent, it could be either the mom or the dad, they have one bad copy, and that bad copy is sufficient to cause a problem with, for example, the brain or the eyes. Now, when they have children, there is a 50% chance that the child will inherit the bad copy from the parent, and then they will be affected. So unlike a recessive disease, where the chance of having an affected child is 25%, in a dominant disease, the chance of having an affected child is 50%, because the good copy is not sufficient to compensate for the bad copy. The reason why this is relevant for Wolfram disease or Wolfram syndrome is because initially, when they did the genetic studies on families with classical Wolfram syndrome, with diabetes insipidus, diabetes mellitus, optic atrophy and deafness, so-called DID mode syndrome, they found these mutations, these spelling mistakes in this gene called WFS1, and both copies had a genetic mutation, meaning that this was behaving in a recessive fashion. I'm not going to talk too much about this because I'm sure someone else will have done this in much greater detail, but the Wolframin protein is located on the endoplasmic reticulum. And what is quite fascinating about this is I spent a lot of my time doing work on mitochondrial disease, but we do know that there's a very close relationship between the endoplasmic reticulum and mitochondria. And therefore, mutation in WFS1 will result in dysfunction of your mitochondria, which will affect the amount of energy being produced, which will affect the amount of calcium being stored in various compartments. And all of these will be contributing to eventual cell dysfunction and cell death. And the reason why it's crucially important that you have mitochondria in your cell is because they produce most of the energy that you need for normal survival. So again, the analogy is very good here because these mitochondria are tiny batteries that essentially allow your cell to work normally. If you end up with either a problem with the mitochondria, or in the case of Wolfram syndrome, where a mutation on the endoplasmic reticulum affects your mitochondria, eventually you're going to run out of energy. And as soon as this happens, there's a cascade of events that happens within the cell, and this results in the cell eventually dying and not being able to contribute anything to the organ. So I've just mentioned already that you are born with quite a large number of these retinal ganglion cells, 1.2 million. And what happens in WFS1 disease, you end up activating a number of factors which is detrimental to cell survival. You end up not producing enough energy. You end up having an imbalance in terms of calcium transfer between all these compartments in your cell. And then eventually, you end up with your retinal ganglion cells suffering quite a lot, and then eventually deciding that they can't cope anymore and they will die. And as you lose these retinal ganglion cells, the optic nerve becomes progressively more damaged and the visual loss starts to accelerate. And for the majority of patients that we see in clinic with suspected or confirmed Wolfram syndrome, they will have two bad copies of the WFS1 gene. So this is a recessive form of Wolfram syndrome. But what has become quite clear, especially over the past 5 years, is that you can have people with a form of Wolfram syndrome, which tends to be milder, where they have only one bad copy. So there's a mutation, one WFS1 copy, the other one is normal. And in this case, this is a dominant form of transmission. The reason why this is relevant is because recessive Wolfram syndrome varies differently from someone with dominant WFS1 mutation. And gradually over time, as we've been investigating these patients, their families, as we've been seeing them for longer, it's become much clearer to us that these dominant WFS1 mutations are linked with much less severe clinical disease. Of course, they will have optic atrophy because this is a central component of the condition. Sometimes this can be linked with hearing loss, but very often they do not have any other significant neurological defects, and some of them don't even have any diabetes. It's clearly limited to the optic nerve. So we did a study recently. It's currently being reviewed in the literature, so we hope that by early next year it will be published. But we looked at 37 patients seen at Moorfields Eye Hospital with confirmed WFS1 mutations. So all of them had optic nerve involvement, all of them had visual loss, some of them being mild, others being much more severe. And the average age at which the diagnosis was made was around 15 years old. But there was a big range. And the reason why I had people presenting very late on is because they had a very mild form of the disease. They got their driving license, no problem at all, but then they reach their 50s and then they start having problem with their vision, and then someone spots that the optic nerve might not be completely normal. Out of this group of 37 patients, 18 of them had recessive mutations and 19 of them had dominant mutations. So when you come to see us in clinic, we'll be doing various examinations, the most important one being looking very carefully at the back of the eye, using either the slit lamp, which is what you see here on the top left, where we use a series of lenses to focus at the back of the eye, or sometimes for children, it's much easier for us to use this other form where it's a bit like a headlight lamp, and it's easier to be able to maneuver things when you have to deal with young children who might be less cooperative. So when we looked at the group of patients with recessive mutations, the average vision was 6/36. So what do we mean by this? So a lot of us have gone to our opticians, either because we need glasses. Some of us will have experience of bringing their children or other family members to the eye clinic. But if you look at the vision chart, the top letter is 6/60 or 20/200 if you're in the US. So the average age of this, the average visual acuity of this group was 6/36, meaning that they could read the second letter on the chart. When we looked at the patients with dominant mutations, the visual acuity was much better. On average, they could make out 6/12, which is the borderline in terms of whether or not you can drive in this country. So already you get a clear indication that recessive mutations cause much more severe and much more rapid loss of vision compared with the dominant mutations. This is just another way of looking at the data, right? So on the y-axis, which is on the vertical line, we have plotted visual acuity, right? And on the other axis, which is the horizontal line, we've plotted the age of the at which the vision was measured. And each line represents one patient. And in terms of color coding, the red lines are patients with dominant mutations, and the blue lines or green-blue lines are patients with recessive mutations. And as the line goes upwards, the vision is getting worse, right? If we basically put the groups together, we merge them, right? We can produce two lines, a single line for the dominant group, which is again in red, and a single line for the recessive group. And again, it's very clear that if you have a recessive mutation, your vision gets worse more quickly and compared with the dominant group. So what does that mean in terms of someone's vision? So this is the change in the visual field for someone that has been furrowed for quite some time. So if you look on the left, you will see that there are small areas that are starting to lose vision, right? But you're still managing pretty well, right? As the disease progresses, you lose more of this central visual field. And then unfortunately, the very center becomes affected. And that's when, unfortunately, the vision will drop quite quickly over time. The other thing that we do in clinic, which is very helpful and hopefully will also give us some indication of what's happening when you do clinical trials, We can also take some images of the back of the eye, right, using optical coherence tomography imaging, right? And it allows us to have a very, very high resolution image of the optic nerve and the retina. And we can use that to generate a value about how the thickness is changing over time. And this is just, again, the data we got from this group of patients. And again, you get significant thinning of the retina and the optic nerve. It's worse in patients with recessive mutations. And this is helpful for us because at least we can advise people that if they have a dominant mutations, of course their vision will be affected, but at a much lower rate. The other thing which I will mention very briefly here is when we do these images of the retina, what we find is patients with dominant mutation tend to have a very specific signal when we look at the images. So if you look at this image here of someone with dominant mutation, you can find this very thin line, which is shown here by the yellow line. And this thin line that we can see, we only see this in patients with dominant mutations. So if I see someone with optic atrophy and this thin line on the OCT scan, my first thought is whether or not this is someone with dominant WFS1 mutations. And we do not yet have an explanation for this. It must be something which is very peculiar to the dominant mutation compared with the recessive mutation. So we've talked about this very important link. The eye produces the signal, the optic nerve transmits the information to the brain, and of course the brain is there to analyze the data. The other thing that we can do is we can measure how quickly the signal is being transmitted from the eye to the brain. And we do that using various recording, which is very child-friendly because we only need to stick little sensors on the face and at the back of the head, and most children can manage that very easily. And then we provide various stimuli, checkerboard signals or alternating light and dark. And by using these patterns, we're able to measure the speed and the strength of the signal as it goes along the optic nerve. So in Wolfram syndrome, without any big surprise, because you have optic nerve damage, the signal gets to the brain at a much slower speed, and the signal is also weaker, which is indicative of the level of damage. So hopefully this gives you an indication about why you lose vision in Wolfram syndrome. Now, the more challenging aspect is how can we prevent this from happening in the first place? So clearly, if we're going to preserve vision, we need to save these retinal ganglion cells because these are the cells that are needed to transmit the signal to the brain. We could do that using various drugs. You will have heard an update from Tim already about the sodium valproate study. We could go down the route of gene replacement because then you correct the actual defect in the cell. Or basically what you can do is you correct the mutation and then use stem cell to repair the optic nerve, which is further down the line, but something which a lot of people are working on. So what about protecting the remaining retinal ganglion cells to slow down the rate of visual loss? One thing that you can do is you can use existing drugs, so-called drug repurposing, which has advantages because it's faster, and some of these drugs are much cheaper, but obviously this is a bit of an exploratory phase because we do not know whether or not these drugs are going to work in the first place. That's why we need to do these randomized control trials. Or much more advanced is, based on what we know about the disease, is can we find specific molecules that have been designed to target specific part of the pathway to try and preserve these retinal ganglion cells. And Fumi must have given you an update about some of the molecules he's using to try and reduce endoplasmic reticulum stress. What we've been doing as well is we've been collecting skin cells from patients with various mutations, including WFS1 mutations. We can use that to convert them to skin cells, stem cells, and then these stem cells can be used to produce retinal ganglion cells. We've also been working on the zebrafish model of Wolfram syndrome, and we are not doing it, but there are many other groups which are working on mouse models of WFS1 disease. So the work which is ongoing now is looking at a zebrafish model of Wolfram syndrome. We've selected a number of drugs that we're going to use to see whether or not these drugs can prevent optic nerve damage in this zebrafish model. And I'm hoping that next year, either myself or the research associate working on this can give you an update on where we are so far. So the one thing which I think we all agree on is how challenging it is to run clinical trials for rare disease. Because not only must we find a treatment that seems to work, but then we need to secure the resources to be able to conduct a larger study. And recruitment is always something that we need to work very hard on when it's a rare disease. So that's what we want. We want a cure, but unfortunately, we have to systematically go through all these stages, keeping in mind that ultimately what is very important is to make sure that any treatment is safe, because safety is the first step, and then hopefully we find a drug that works and improves some features of this condition. I don't have to repeat this to this audience, but we've been very fortunate here to have a very diverse and very collaborative group, in Europe, in Japan, in North America, and this will have to carry on because all these studies will have to be multi-center to be able to recruit enough patients. I'm not going to talk about the sodium valproate study because you've already heard about this from Tim already. Gene replacement, I think, is very exciting because we know that this is something that can be applied very easily to the eye and to the optic nerve. And the aim of gene replacement therapy is just to insert the gene into the retinal ganglion cells to prevent them from dying and to prevent the optic nerve from getting more damage. For us, we've been working on gene therapy on other conditions. The reason why this is an easy target is because the eye can be easily injected. We do that every day in clinic. And also, when we use these viral vectors, because we need to find a vector that allows to deliver the replacement gene into the retinal ganglion cell, we're quite fortunate that there's a whole range of these viral vectors that we can use. We know they are safe, and we can use specific viral vectors that target the optic nerve, in this case, the AAV2 viral vector. There are mouse models out there which are being used to try and explore these gene therapy, and I'm not going to go into any further detail, right? But clearly, this is just a start because these preclinical studies need to be then moved into non-human primate studies, which take time, and then eventually we can move on to human clinical trial. But the one thing why I have a lot of hope for Wolfram syndrome is there are other genetic eye diseases which are at a much more advanced stage in terms of gene therapy, and all of them have shown very clearly that we can use these viral vectors safely. And for some of them, there are very promising results in terms of stabilization or even improvement in vision. In terms of using stem cells, we hear a lot about stem cells in the media, sometimes a little bit overhyped, but this is a very important area that deserves further study, because if we can correct the mutation in these stem cells, then we can use it potentially to replace the cells that have been damaged in the optic nerve. And we can do this now. We've been doing this in the lab, where you can use a very specific form of genomic manipulation to repair where the genetic mutation is located. So once you've used this CRISPR-Cas9 to correct the mutation, then you can convert these stem cells into retinal ganglion cells, and we've been doing that successfully in the lab over the past 3 years. And the aim initially is not to replace the retinal ganglion cells, because this is quite challenging, but to use these retinal ganglion cells to understand how the disease progresses over time, and then to see whether potential drugs can rescue these retinal ganglion cells in a petri dish. So what I think is going to be the way forward is using these stem cells to produce these retinal ganglion cells, and then we can use these for drug screening and also for validating other treatment approaches like gene therapy. So just the final slide here about that optic nerve involvement is a major feature of Wolfram syndrome, a major feature of WFS1 mutations. And when you speak with families and with patients, this is what really worries them, is how quickly will my vision deteriorate, and will there be a treatment that prevents me from eventually losing that very important central vision? It is quite clear that if you have recessive mutation, your vision will get worse more quickly compared to if you have a dominant mutation. Preventing further visual loss is what we're aiming for, because we need to be realistic that at the moment, we cannot reverse the damage that has been done already. But the aim is to stop your retinal ganglion cells from getting worse, from losing these retinal ganglion cells, to stabilize your vision where you are now. And finally, it's a lot of work that lies ahead, but I do think that gene therapy is a very attractive treatment strategy and something that could be a game changer if we get it right. Thank you very much. I'm very happy to take any questions from the audience.
Lovely. Thank you very much for another very clear and concise presentation, Patrick.
Thank you.
So yes, as Patrick says, if anyone has any questions, please submit them now. I have a few that had already been submitted. I think you may have sort of covered them in your presentation.
So there's one question here from Tony Fleming.
Yeah.
Could a Wolfram syndrome patient with a recessive mutation have one parent with dominant and one parent recessive, or is there no crossover? Yes, well, theoretically speaking, you could, right? You could have one parent with recessive mutations, meaning that they are affected with this condition, and then it happens that the other partner has only one mutated allele, right? So yeah, it could happen, but then for the child, then it all depends on whether or not they inherit one copy or two bad copies, really. So it would be the same, right?
Lovely. Question here. We have had access to iPSC cells for some time now. Why is it taking so long to get this to our patients?
Yes, and I will give you my experience of working on a different disease, a different optic nerve disease, which is inherited, called dominant optic atrophy, caused by OPA1 mutations, right? So we started this program about 6 years ago, right? And there are two barriers. The first barrier is that stem cell research is quite resource intensive and very expensive. It's taken us nearly 2 years to optimize the differentiation of these stem cells into retinal ganglion cells. Now we've done this now, and then we're moving on to the next stage of using these retinal ganglion cells from stem cells for drug screening and for gene therapy. The reason for this delay is very much to the fact that it is something that it takes about 2 months to be able to grow a stem cell into a retinal ganglion cell, right? So it requires time, money, right? And also at the same time, we need to start collaborating more with industrial partners. So I share your frustration about this, but it is something which has potential, but is very labor intensive.
Lovely. Next one. Is there a specific recognizable pattern to the RGC loss in WS as far as temporal, medial, superior, etc.?
Yeah, very good question again. And in other conditions, there is a very clear pattern where specific parts of the optic nerve gets damaged first. My general impression from Wolfram syndrome, from some of the data we've collected, is that you tend to get a more rapid global loss of these retinal ganglion cells, right? And this accounts for the reason why most people with Wolfram syndrome will present in early childhood with features of visual impairment, right? There are other genetic conditions where the disease progresses much more slowly, and then you can get a specific pattern where the temporal quadrant is affected more in the early stages. So I think the key feature of the retinal ganglion cell involvement in Wolfram syndrome is a much more rapid evolution, which a lot of people on the panel will appreciate, either from having children with this condition or being affected themselves. And there's a question about is the retinal ganglion cell loss steady progressive, or does it progress with lack of predictability? There's a lot of variation, right? Which is what makes it difficult sometimes to provide counseling over a long period of time. Generally speaking, with Wolfram syndrome, you start to lose vision from an early age. It tends to be a much more rapid loss of vision compared with other genetic conditions like OPA1 dominant optic atrophy. What we do not know is whether or not, as you grow older, whether the loss accelerates. There is potential indication of that, but we do not have enough data to be able to say, really. But the key feature of Wolfram syndrome is the early and more rapid loss of these retinal ganglion cells. Does this accelerate or plateau over time? We do not really have enough data to say this.
Lovely. Next question. Is there any similarity between optic atrophy in WS and in LHON? Idebenone is approved as a drug for LHON. Is it also recommended for WS?
Right. Optic atrophy, right, the pattern of the optic nerve, is a descriptive term. So whether or not it's Leber's optic neuropathy, whether it's dominant optic atrophy, whether it's Wolfram syndrome, or whether it's optic atrophy from MS, the nerve becomes pale. It is just an indication that the nerve has been damaged, right? To your question about idebenone, this is obviously a treatment which has been approved for use in Leber's optic neuropathy, right? There is one anecdotal case report of potentially using it for Wolfram syndrome. I think the jury is out there. As part of this zebrafish work that we're doing in the lab, which is ongoing at the moment, one, the drug that we're testing in the zebrafish is idebenone, right? And, hopefully this will give us an indication. Now, let's fast forward. Let's in a year's time, we find that idebenone does improve the optic nerve damage in the zebrafish. Now, the other key question is, how do we move on to doing clinical trial for this condition? But I think we need to do it stage by stage. But definitely, idebenone is a candidate drug because it has been shown to work in another form of inherited optic nerve disease, and it also improves mitochondrial function. But sometimes what looks right on paper does not always materialize when you actually do the experiments or when you do a clinical trial in your patient group.
Lovely, thank you. A question here. In a recent paper, authors found 9 patients out of a cohort of 300 with monogenic diabetes who had type 1 diabetes, but they claim no other symptom. Do you think that this could be a subgroup of Wolfram patients?
Yeah, and it is something that we still need to get our head around. And what is central about this is that ultimately you have someone who has a mutation, a genetic defect in the WFS1 gene, right? So it's a key unifying factor. At one end, you have what is the historical Wolfram syndrome DID mode, where you have a whole range of these clinical features, and it's caused by recessive mutation. And on the other end of the spectrum, you have these milder dominant mutations where someone can have only optic nerve involvement. They could have a bit of optic nerve involvement, a bit of hearing loss, and potentially they could also just have isolated diabetes. So I think, it is a spectrum, right? It is a spectrum from the very severe historical description to what we know now being very mild cases, really, right?
Lovely, thank you. No other questions coming through at the moment. Just a quick look on there, nothing in chat. So I think that might be it. As I said, here's one here that can go to both you and to Tim. The question is, how are diabetes and sight in WS connected? What is the scientific reason? Right.
That is probably one of the kind of good thing about Wolfram syndrome is, of course, anyone with diabetes can develop diabetic retinopathy, i.e. the diabetes affect the back of the eye, the retina. But generally speaking, in Wolfram syndrome or in Wolfram spectrum disease, people don't tend to get major complications from diabetes affecting the back of the eye, right? That is not to say that you should not have a very good glycemic control, but you don't tend to get diabetic complications affecting the eye in Wolfram syndrome, at least in my personal experience.
I agree with you, Patrick. We see very little diabetic retinopathy in patients with Wolfram, thankfully, which is good. The other connection, I suppose, is if diabetes control is not ideal and sugar levels are chronically high, that can cause increased stress on cells, and we know that increased cell stress contributes to the loss in Wolfram syndrome. So there is some tentative evidence from Dr. Julia Rohaim in Germany and others that really good diabetes control probably helps overall in Wolfram. So that's why we try and optimize diabetes control as much as possible.
I fully agree. And, you know, we also see other conditions, other optic nerve conditions, which tend to affect people over the age of 50, where diabetes and poor glycemic control is a very clear risk factor. And, you know, it's very easy to imagine how it would be, because the disturbance in terms of the high blood sugar can affect the vasculature, the way the metabolic compensation. So absolutely, although you don't get severe diabetic complication, you absolutely need to get your blood glucose under control for these reasons just mentioned. There's a question here about whether or not knowing the structure of Wolfram will give us clues about how the endoplasmic reticulum and the mitochondria are connected. Absolutely, right? You know, this is still a very vague concept. We absolutely know that the endoplasmic reticulum communicates with the mitochondria and other organelles, and we do know that there is a very intimate connection mediated by various factors, including WFS1. We do not yet know what are the players involved in this kind of inter-organelle communication, and all of this will give us clues, really. But I think as soon as we build up the little building blocks of how these two are connected, what are the factors involved, then it could potentially be that by increasing the expression of some of these components, we might be able to compensate for the lack of the WFS1 protein. So this is all pretty cutting edge, pretty hardcore science. And, you know, personally, I'm relying on other people to do this, because, you know, I'm not someone with the scientific knowledge to do this kind of work, really. Yeah.
Lovely, thank you, Patrick. I don't think there's any other questions, and we're almost at the end of our session. So I'd like to thank you for coming on and giving your presentation today. Look forward to hearing the progress that you make at our next catch-up, next conference, which we very much hope will be face-to-face, and we can have some sort of normal. So just like to say thank you again. Thank you, Tim, as well, for joining us on this one. Yes, the recording will be added onto the website. And for those of you that are continuing on, I'll see you again in 15 minutes.
Well, Tracy, thank you very much. And, you know, fingers crossed we can all meet in person next year, really, right?
Lovely. Thank you. And keep up the great work that you and your team are doing.
Okay. Bye-bye, everyone. Nicole.
Thank you. Bye.
See you, Patrick. Bye.